Thank you so much for joining us.
I don't know many people on the call, so my name is Krish. So I'm one of the HPB liver transplant consultant surgeons at King's.
Yeah. Hi, Mr. Menon. I'm Mohammed. I'm helping with Moroccan the TUGS Lounge, and I'm a trainee in London. So
in London,
nice to meet you. Yeah, North Central East London. Yeah.
Okay.
Royal Free. Currently.
Royal Free. Yeah. The wrong side of the river. All right. Yeah, no, London geography is minimal. I don't know much about it. I just come there, visit the touristy bits, and come back home. Yeah. So I can see Liz. Hello, Liz. Evening.
Hello. Thanks for inviting me. I should say hello.
No, it's a pleasure. How are you?
Know me. Liz Gavin, one of the GI surgeons at King's Mill, which is North Nottinghamshire.
Nice to meet you. Yeah.
Good. And I can see Javed as well. Javed, hello. Evening.
Evening. Thanks for the invitation. My name is Javed. I'm not a surgeon at Salford. Nice to see you all.
No, it's a pleasure having you, Javed. Obviously, go through. We'll wait for everybody to join in. We'll go through introductions formally. We have had about over 150 registrations, so we'll see how many join.
Right.
Usually, we have about 70, 80, up to 100 people joining for these. And I think this time I was checking, a lot of consultant colleagues have registered for this. Not many trainees, I guess they're not involved with one yet, but
great.
You can wait for a few minutes, Mr. Madam, just to allow people
Sorry,
to
say that again, Mohammed.
No, I was saying we can wait for a few minutes just for people to join, and then
We'll give them about 5 minutes, before we join. Before we start the meeting.
Brijesh, is Catherine Smith the same Catherine Smith who used to be our SHO in Leeds?
That's right. Yeah, wow. She's the same Catherine Smith. Yes. She's a colleague of mine at Derby now.
Wow, wow.
Yeah. The same Catherine Smith.
Small world, eh?
She
makes you feel old.
It does happen, but I think that's the idea. So I think again on the panel we have got a good combination to learn from each other's experience.
I think it's a great topic as well. I think
So I think Kalpana has joined. Kalpana, hello.
Can't see myself, so I wasn't sure whether I'm joined.
No, we can see you. How are you? Thank you so much for joining us.
Thank you for the invite. I was just trying to figure out, because I'm not very familiar with Zoom, but yeah, it's working, so it's good.
Well, you've done well. Thank you so much. Yeah.
Thank you.
And and Miss Smith is here as well. Catherine, hello, evening. How are you?
Hello, good.
You finish your robotic list on time then?
Yes, for once. Yeah, thanks.
No, thank you so much for joining, Catherine.
Hi, Catherine. Long time.
Hello, I know. I saw you on the thing and I thought, blimey, it's been decades.
Yeah.
How are you?
I'm all right. Yeah. So I moved from Leeds, being 11 years in Leeds, 10 years now at King's. Yeah.
Gosh, wow.
Yeah.
From the north to the south.
North to the south, yeah.
Quite a big leap. I can't get over this beard, Bridge.
You can't get over what, sorry?
Your new look.
Oh, this look. Oh, sorry. Yeah, no, it is a new look, Kalpana. Yeah. I think I just got bored one day at home with COVID, so thought of trying something different. I'm told it makes me look older, about 10 years older.
It's not November, isn't it? It's it usually
Not
we
yet.
see
No,
that
no.
in.
I think I started early this year.
Yeah.
Jamshed just joined in. Hello, Jamshed. Thank you so much for joining us. Jamshed, I think you're on mute.
Can you hear me now?
Yes, we can, Jamshed. Thank you so much for
very much.
joining us. Yeah,
Thanks for the invitation.
it's a pleasure.
I'm going to make you a co-host, Mr. Shabir. Hello.
Hi, how are you?
I'm all right, thank you. So I'm going to make you a co-host as well so we can share the presentation.
Mhm.
I think. Yeah.
Okay, I'll try to. Can you see the screen?
Yeah, you can see it. Yeah. So it's working fine. Yeah.
Thank you. So let me know whenever you want to start.
Yeah, we're just waiting for a few minutes. Do you want to start, Mr. Maddock, or shall we give a few more minutes?
Yeah, I think we can make a start.
Yeah, I think so.
Yeah, I think they can join even later, isn't it?
Yeah.
Make a start. Thank you.
Okay, thank you very much for the invitation. I am a colorectal surgeon in Bristol, and Mo got in touch with me.
Yeah, thank you, Mr. Shabir, for joining us today. I'm very honored to have you in our TUGS Lounge. So welcome everyone to the TUGS Lounge. I'm Mohammed Abu Nazaim. I'm a surgical trainee in London, helping with Mr. Maddock with TUGS Lounge, coordinating the TUGS Lounge. And we are talking today about a very common topic, which is impact of complications on surgeons' well-being, psychology of surgeons as well. So our first speaker is Mr. Shabir. He's a consultant colorectal surgeon at University Hospital Bristol, and he has a subspecial interest in IBD and surgical education and training. He has also published on this topic before, so he's here today to tell us about his experience in this topic. Thank you very much, Mr. Shabir, for joining us.
Thank
Of course, I won't forget
you.
Mr. Maddock, who was the main main runner of TUGS Lounge. And Mr. Maddock is, of course, upper GI and bariatric consultant at Royal Derby Hospital. Thanks, Mr. Maddock, for giving me the opportunity to help you in this TUGS Lounge.
Mohammed, it's a pleasure. Thank you so much. Without it, it wouldn't be possible. And you underestimate by saying you are a surgical trainee. I think you're one of the pillars of TUGS, and you've helped the association so much to develop. So really appreciate your help. Jamshed, just before we start, I'll just like to take the opportunity to introduce our chairs formally. They have introduced briefly all of them. So I'll just take 2 minutes to introduce all of them, please. It's an honor to have this fantastic panel with us today. And together, I think they bring a lot of consultant experience and hopefully help us how to deal with, or, how to sort of look after ourselves. That's the idea. I think we're not talking about dealing with the complications surgically, but how to look after ourselves. Surgeons' well-being is the key thing. So it's an honor to have Mr. Krishna Menon with us. He's a consultant liver transplant and HPB surgeon at King's College Hospital NHS Foundation Trust in London, and is the lead for liver transplant surgery at King's College Hospital. Krish is the president of the Great Britain chapter of the International HPB Association, and is also currently the vice president and the president-elect of the British Transplantation Society. He's got major clinical interest in laparoscopic liver and pancreatic resections, and research interests include pancreatic cancer, clinical trials, and development of novel technology in cancer and laparoscopic surgery. He has published over 125 peer-reviewed publications and has got presentations, over 300 presentations at national and international meetings. Mr. Menon, it's a pleasure to have you with us today. Thank you so much for joining us.
Thank you for the invite, Brijesh. Thank you for your very kind introduction.
Thank you, Krish. It's an honor to have Kalpana Devalia with us. I've known Ms. Devalia for a long time, and I attended her fantastic Homerton course. She's a consultant bariatric surgeon at Homerton Hospital in London. Kalpana, welcome, and thank you so much for joining us today.
Thank you. Thank you. It's fantastic to be able to join. Thanks.
Thank you. It's an honor to welcome Javed Sultan. He's a great friend and colleague. He's a consultant esophagogastric surgeon at Salford Royal Hospital. He trained in Newcastle and was a substantive consultant in Guildford for about 5 years before he decided to come up north to Salford. I think right decision. Is now the clinical director and the head of the department. Javed, it's an honor to have you. Welcome.
Thanks for the invitation. A very interesting topic, so thank you.
Thanks, Javed. It's an absolute honor to introduce my colleague, Ms. Smith, Catherine Smith. She is my colleague at Derby and my buddy consultant colorectal surgeon. She's the one I shout out to come and help me out. Catherine is the clinical lead at colorectal surgery at Derby. She's also the training program director for core surgical training in the East Midlands and the lead for CST education nationally. Catherine, thank you so much for joining us. It's an honor to have you today.
Thanks, Bridge. That's it.
Thanks, Catherine. And last but not the least, we have Liz Gimmel with us. She is an upper GI surgeon at Sherwood Forest Hospital. Liz, I've known her for a few years. We have done some courses together. She's trained in East Midlands and Oxford, and she's the head of service of surgical gastroenterology, plus a college tutor at Sherwood Forest Hospitals. And Liz is also the regional rep for ASGI. Liz, it's an honor to have you with us today. Thank you so much for joining us.
Thank you for the invite and a very important topic.
Thank you, Liz. Jamshed, if I can please invite you to share your screen and you can start the talk, please. Thank you.
Thank you. Are you able to see my screen now, or? Yeah.
Yes, we are. Yes. Thank you.
Thank you. So as the topic says on the slide, it's not about how to deal with complication. It's about what impact they have on the operating surgeons and what can we do to improve surgical well-being. So just a bit of background, we are all familiar with the term second victim. It was popularized by Albert Wu, an American physician, in the year 2000 to describe the impact on clinicians when they're involved in medical error. And as you can read on the slide, it is all those feelings which one goes through, that you feel singled out and exposed, you agonize about what happened, and then replay that event again and again in your mind, trying to find a solution. And from there, the term second victim literature, and it is to discern toward event or serious harm. And in a way, they are victimized by the event which happened either in theater or during the patient journey. So symptoms of second victim have been well described, and most of this comes from the American literature. They're actually not in the American literature, very little in the UK literature. So Scott et al. Described this from physical to mental symptoms, ranging from fatigue to hypertension to flashbacks, grief, remorse, loss of confidence. And what do the second victim go through, or the clinicians go through when a serious incident happens? They're concerned about the patient itself. I think that's the primary concern which comes straight to your mind. Is the patient or the family going to be okay? How will they respond to this bad news? What will my colleagues think? Will I be trusted again? Will I be a respected member of the team if you have a serious unexpected event? And then you start thinking about yourself. You have self-doubts, you have concerns about the litigation, about being reported to the GMC and the long-term consequences of those complications. So all this goes through the individual's mind while they're trying to rescue that patient from a serious complication. Again, another paper from American literature, if you look at it, the key thing on this slide is the bars in red, that people who were involved in a serious error had more feelings of anxiety and decreased job confidence and all the symptoms of second victim compared to those who were in minor incidents. But the important thing is the 90% of physicians did not feel that the hospital adequately supported them, and more than 80% would be interested in some support and counseling. This paper in JAMA beautifully describes what one goes through when you hear that the news of when something goes wrong, that you get that feeling of kick in the pit of your stomach. You start thinking about what happened to the patient. And then comes the fall stage, and that's when you start replaying that operation you did 2 days ago and start replaying it in your mind again and again and start thinking of any steps I could have done different. Then you move on to recovery, where you start to plan rescuing that patient and also rescuing your reputation and your interaction with colleagues and family, and then long-term consequences result from that. And that could be lack of confidence, that could be self-doubt, or you seek support. And if there's a good network around you, you just take it on the chin, you move on and learn from any error which is made. And again, this slide describes the 6 stages of that recovery. And in the end, you either thrive, you survive, or you drop out. So dropping out doesn't happen that much in our training system or in our healthcare system, but it is quite common phenomena in American healthcare system from where most of this literature originates. And this is just explanation of the same 6 stages. You can see from chaos to intrusive reflection, personal integrity, enduring inquisition, emotional first aid, and then moving on, which could be dropping out, surviving, or thriving. Those who drop out are usually clinicians who are involved in more or serious incidents which have resulted in either a life-changing event for patient or resulted in patient death. And the bottom left block on this slide gives a list of the situations in which people are more likely to drop out. So with this background, we decided to do a survey of our colorectal surgical society members. We sent about 110 questionnaires to surgeons who consented to take part. We got 82 responses. As you can see, 91% were consultant surgeons, and majority of them were experienced surgeons of more than 15 years. I go through the questions which we asked, and you can see, have you been involved in any serious complication in the last 5 years? Nearly 95% had had a major complication in the last 5 years of their practice. Emotional impact it had on them as an individual, and you can see the same feeling which were described in the medical literature, ranging from guilt to worry for patient, sadness, anxiety, and anger. One surprising bit was none of the above, and that was one individual. I don't know who that was. Did it affect your surgical practice? And you see the same common themes appearing, which are consistent with the published literature. The patient became risk averse, conscious effort to avoid taking similar cases, rumination. But encouragingly, 60% of them were involved in reflective practice, and they learned from the mistakes or errors and moved on. Did it have a negative impact on the family life? And not surprisingly, more than half the individuals agreed that it had impacted on their family life, their interaction with their partner, and it was a negative impact on their family life. Did it have negative interaction with their colleagues? Not that much. Probably colleagues are the one you rely mostly in these situations. What factors affect your response to the complications? So mostly concern about the patient and their family, especially if the complication arises from elective surgery, where you have a patient well prepared and you're trying to do an elective operation, and if you have untoward event from that, that is probably affects you more than somebody who comes in through the emergency resus. And reaction of the colleague was surprising finding in this. Who do you turn to for support? And as expected, more than 70% people were looking for support from their colleagues. More than half were relying on the family support, and less than 10% were getting professional counseling. But more alarmingly, 25% had no support. How do you alleviate the stress you experience? And again, colleagues and family score fairly highly in response to this question. But if you can see at the slide in my cursor, about 10% of the people admitted that the drinking alcohol increased while they were struggling to cope with the consequences. We did not include drugs on purpose in this question, but you can see that people did find other ways to cope with the stress. What support is available in the institution? So very little professional counseling and support, mostly peers or mortality and morbidity meeting, very little mentoring, and 10% of the people say there was no support whatsoever in the hospital to help them cope with the situation or to come out of it. And not surprisingly, 55% said they thought the support in the institution was inadequate. What do you think are the barriers in seeking support? Macho culture in surgery? Well, I think it was quite common maybe 20, 30 years ago, but I think it's less so. But still, I don't think we've completely got rid of that macho culture in surgery yet. It is much better environment now and much more supportive, but I think it still exists in isolated corners. Hierarchy still exists. About 70% said their workload was too high, and 30% they didn't want to burden other people with their worries. What do you think should be done? And not surprisingly, people want an open and fair culture where you're not blamed, but you're actually supported, in culture where you learn from mistakes, structured debriefing, which is quite common in the airline industry. We still haven't got to a point in our profession where we have structured debriefing in such incidents. We do rely on root cause analysis, but I don't know how supportive they are. And there were some free text comments, which I'm not sure how clearly this slide is projecting for you. But you can read, there were some interesting comments from the participants. And again, the same theme comes that supportive colleagues are key to dealing with these issues, as was highlighted in the survey. But then if you look at the literature in 2019, Melissa Clarkson and colleagues wrote another editorial in BMJ, and they say, should the term second victim be used at all? And they argue that second victim term is not suitable for medical profession because it just tries to suggest that patient harm is random and it's caused by bad luck and not preventable, because victim are supposed to not bear any responsibility for what's happened. And as a result, we're trying to say that the medical profession is not responsible for what went wrong with the patient. And all these authors on this editorial are individuals whose close family members suffer serious harm or death as a result of medical errors. They have a point. I think second victim may not be the right term to describe, but that doesn't take away from the fact that people who are involved in these serious incidents, it does have a negative impact on their personal and professional life, and they need to be looked after along the patient and the family who are on the receiving end of that complication. So when should you seek medical advice? Well, it is normal to experience upsetting and confusing straight after the event, but if you're still feeling the same anxiety and the same symptoms which I described earlier, 6 to 8 weeks after the event, and you're re-experiencing the event, your avoidance and emotional numbing, or you are irritable and hyperarousal, then that's the time to go and see somebody and not just to be on your own. These slides just explain what re-experiencing the event means. You're getting flashbacks, nightmares, or physical symptoms as a result of it. Or you're trying to avoid, you get isolated, you're trying to avoid people and colleagues. And sometimes you'll see some colleagues will try to avoid even go and see that patient and family, and they'll send the registrars to see them. And that's not because they are trying to avoid them. They just can't face the situation because they feel so isolated and alone. People react differently. They can get irritable, angry outburst, insomnia, difficulty concentrating. So all those symptoms are the time, and you think it is the time you need to go and seek help. And there is reported incident, as you can see, 10% of the respondents in our survey said their alcohol consumption increased significantly as they were suffering or recovering from this serious incident. So what can be done and should be done? Well, this is again comes from the American literature. They think that should be 3 tiers of support in every institution. Tier 1 is local or departmental, where you have your colleague and peers to support you through the difficult time after the incident. Tier 2, where you should have trained mentors in the hospital, which could be your medical colleagues or risk managers or patient safety managers who can support you through that event. And if you are struggling weeks and weeks after the event, then you need to get professional counseling or psychological support. These are some useful resources. I think our survey was done before the pandemic. I think there was lack of well-being setup and culture in the NHS before that. I think with COVID-19, there's been a lot of emphasis put on the staff well-being, and certainly in our institution now, there is a 24/7 professional counselor helpline available if somebody wants to ring them about anything. That includes if they have had a serious complication, they can seek that professional support. So I think maybe so we have learned something from COVID pandemic, and it will be, and the well-being culture will improve in the NHS, but certainly there's a long way to go, I think. Thank you.
Thank you very much, Mr. Shabir, for such an excellent presentation. And I can see that the last comment says that every surgeon should carry within himself a small symmetry. So it's, I think it's a very fine balance to try to find between, as a surgeon, between not being bothered by complications or the other extremities, the complications really affecting your life and your psychology and having personal effects as well. So thank you very much, Mr. Shabir, for such a great presentation. And I would like to ask Mr. Menon for any comments. What do you think, Mr. Menon, about this topic or your experience with this?
I think thank you very much. That was a great talk. I think, you covered so many facets of dealing with complications and the effects of complications. I think I'll start with the last bit because I love flying. And I think everything is to do with flying. I think if you look at the flying industry, and any of you who watches air crash investigations will know that everything that has made flying safer is because of the lessons learned. So I think as it comes back to surgery, my question to you is, I think, should we not, as surgeons, immerse ourselves in the complications to learn from it? And half the times we don't do our M&Ms properly because it's all about a little bit about blame game, depending on where you're working, a little bit about finishing it quickly and not coming to a proper conclusion. But ultimately, if you immerse yourself in every single complication you've had and set out your next chart for that not to happen, you'll get better at surgery. That's how you reduce complications. You reduce complications not by some magical surgical maneuver. It's about a lot of things, as we all know on this call, that brings it together. But the most important thing is not having that fear when you get a complication, but immersing yourself in it and actually learning every step of what went wrong. And to some extent, I think I'd like to hear what you think, but I feel paranoia is the name of a good surgeon, another name for a good surgeon. The more paranoid you're about your way you deal with it preoperatively, intraoperatively, postoperatively, you will then have a process in place which will help you. And the most important thing is a colleague. Have a colleague, with you who you can talk to. So I don't know, I'd like to hear what you think.
I think I agree. I think we, as you see in this survey, more than 70% of people rely on their colleagues for their support. And one has to learn. And I think you can't be a surgeon, you can't practice this profession unless you learn from your mistakes, because the more complex work you do, the more advanced operations you do, you're likely to have complications. I think it's not, so there are two aspects: A, to learn from your complication, and that everybody does that, but it doesn't deny the fact that while you're doing that learning, it does affect you mentally and physically. I think, having personal experience, I know that after a major complication to a patient of mine, I really struggled for 3 months early on in my career. And I relied heavily on my consultant colleagues to support me through that 3-month period, and managed to rescue the patient, and it was fine. But that was a difficult time where I think my wife had to listen to me every evening for half an hour. What happened? What did I do? What did I speak with the family? So we rely heavily on our family and on our colleagues. Where we are lacking in the NHS is that institutional support. We do the RCAs, we do the 72-hour reports, but that reports are all about to tell the patient and the family. Nobody ever asks you, how are you, Mr. Shabir, or how are you, Mr. Menon? Are you feeling okay after what happened to the patient? And that's the culture which we need to change. I think surgeons will learn from mistakes and errors. I don't believe that any surgeon goes into theatre trying to harm their patient. But this is the consequence of what we do. Unfortunately, it will happen to the best of us. And what we are lacking in the NHS is that culture, that how are you as a surgeon? Nobody asks you that question. We do everything else from learning, but that physical, mental support is still lacking, I think. It's getting better, I think, but it's not there where it should be.
And do you not think that the reaction of what you face in terms of consequences from the heart stopper moments as a complication versus the time to ponder complications? Because the heart stopper ones are, you got to make a decision, you get it wrong sometimes, you end up losing a patient. That is a GTN moment, which not many of us want to see, but it happens sometimes when you do complex surgery. And did your survey distinguish between, the level of the consequence of whatever complication happened and the effects on the individual?
Yeah, so the complications which we refer to were major life-changing, where the patient either died or they came to serious harm, life-changing harm. They became TPN dependent, or they became physically disabled as a result of complication.
Thank you very much, Mr. Shabir and Mr. Menon, for the great comments. We were supposed to have Mr. Ashok Bora today with us as a second speaker. He's a upper GI and bariatric consultant in Royal Derby Hospital, but unfortunately, due to urgent travels, he was not able to join us today. So, Mr. Maddock, I think he done a study as well about this topic. Mr. Maddock, do you want to comment on this, or?
Yeah, thanks, Mohammed. I think just a couple of things. Jamshed, thank you so much for the presentation. I think Ashok was going to talk about, he has done a similar survey, and this is it is a UK-based survey that he has done looking at psychological impact of complaints and litigations, so not complications, but when you have a complaint, maybe from the family, or litigation, you've got a letter from the lawyers, or even GMC referrals. So I think he was going to share about it, but I think probably it may be a different topic. But I would like to know, what do we put that in a similar boat as complications? You've got obviously once you had a major complication like the ones you're describing, then these things will follow or may follow. So what do we think on that? Are we thinking, as you rightly mentioned, when these things happen, we are thinking on those lines, and these are probably contributing to the psychological impact. But I would like to know, maybe Catherine, if I can ask you, what do you think? Do we think once you're the complication, we are dealing with that, dealing with the complication that has happened, or we are thinking further about the the litigation that is due to come, or the complaints that is due to come? How do we deal with this?
Yeah, I mean, that's the difficulty, isn't it? Because we'll all have had some complications that led to a complaint or litigation, or maybe even the coroner's. So you have all that added extra stress that you experience until you're a consultant, really. I think I find complications exhausting, because you just analyze everything so much, thinking, what could you have changed? And you just can't think of anything that. So it can be really exhausting. When it does, or the coroner's, when you then get another complication, you can sometimes just assume that all of that will happen again. So you see catastrophizing in your mind. You think, oh gosh, that's going to be another PALS and then a litigation, and that whole process of how you're dealing with it is really damaging to us, because of course they don't all go down that line, because there genuinely is room, well, there is error, and there are complications in what we do. It is part of the job, and they don't all end up like that. But that catastrophizing that we can do is really, really harmful. And I think when it comes to complaints, and isn't there
I think your line is. I think your line is cracking, Ms. Smith.
Oh, I'm back.
Yeah, we can hear you now.
I don't know if it was me or you. I don't know where I got to, but I was just saying that when it comes to complaints, litigation, I don't think the institutions are there for us, because we're saying again and again, please don't put the subject as PALS or complaint or legal, or it's so harmful when you see it flash up in your inbox. You just assume something terrible is going to happen. So I totally agree, but I find the whole thing exhausting. But they don't always end up with a complaint. That's one thing. And the second thing is to not be so surprised when you're going through a complaints process, is to go in there with the right mindset. And sometimes I realized that I used to go in there thinking I would be able to, they would be leaving happy. But that's often not the case. So don't expect that to happen. But that was always my expectation, that I would be able to chat it through, reason it all out, and they would leave feeling really happy and content. But at the end of the day, they had a complication, so they're not going to be happy about it. And so if you go in kind of just managing your own expectations, that I felt I came out less damaged from that, just by changing my own mindset.
Yeah. Right. Thank you very much, Ms. Smith. If I can ask you then, Ms. Devalia, what do you think about these complications? Do they affect you personally, or how do you try to get out of these feelings or negative impact from these complications?
Yeah, it's a fantastic topic, and thank you, Jamshed, for really highlighting so many important points. And it's interesting that, it affects almost every surgeon, but how unreported it is, and how many, there are just a handful of articles published over so many years, which really struck me, because I was just looking to see whether there was how much literature was around. So I think it's a fantastic questionnaire study that you did. And I was just looking that there was a coping review published, the latest one in 2021, looking at all the studies in the annals, wasn't it? Annals of surgery on medicine and surgery. So it just shows that how unreported and how difficult it is for the surgeons to come forward and talk openly about it. And I'm impressed in your review that the surgeons are relying on colleagues. But what sort of stands out in your study is that they are all senior surgeons, and seniority has a huge impact. I can remember that, when I just started as a consultant, I was absolutely terrified, something going wrong, and you're still learning, and you want to make sure that at least in the first few years of your consultant job, nothing goes wrong, and you find that the mortality morbidity meetings, however you feel that you can be open about it, there is not a great culture in the NHS in these meetings, and people are not open about it. And I feel that there could be a lot more support, and I think the senior surgeons probably need to take a stand, because I think the juniors are more vulnerable and are more sort of unwilling to express their emotions. And when I was looking at the review, apparently being a female has a more negative impact. I don't know whether I was just intrigued by that, because I think females surgeons apparently take it much more personally. And I feel that that probably is true in some ways. The macho culture, I think that most surgeons stereotypically feel they're strong, resilient, and maybe don't express, whereas females probably express it more and feel more vulnerable in these situations. And I think as you get more senior, you obviously, as Catherine mentioned, the mindset you develop so many strategies and, reasoning and hobbies and other things. Obviously, your colleagues, they respect you more because they've seen you working hard over the years. So I think all those factors play a very important role. And I feel that the culture is the key. It really needs to change. And I think the more support, I don't even know what support exists in my own trust, to be honest. But yeah, I don't think there is any awareness of that is if there is any support available. And I think it has to be more awareness, and the chair for the mortality morbidity audit, the lead, probably can play a very important role in making it really fair and supportive for all the surgeons to open up and talk openly. And I think the things that worsened with Zoom and Teams meetings, where you really cannot express yourself properly and talk to each other face to face, and it probably dampens that. Sorry if I have exceeded the time limit, but it's very interesting and really well presented. Thanks.
Thank you very much, Ms. Divalia. I think there's a lot of factors that can impact the effect of these complications in surgeons, especially as you mentioned, Ms. Divalia, whether it's a senior or a junior surgeon still in the first few years of the consultancy. So, Ms. Jamil or Mr. Sultan, just wanted to get your experience on this, your comments, and also do you think how can we prepare like junior surgeons from trainees perspective? We don't usually get the responsibility as a trainees for the complications. Usually the consultants get these, but how can we prepare the trainees or the senior trainees for this transition into a consultant?
Yes, unfortunately, complications are only really faced when you're a consultant and you're dealing with things independently. But I guess if the juniors are in an environment where they learn from the M&M of how to have reflective practice, teamwork, changing surgical techniques based on complications, they learn that from the beginning, and they can take that into their own surgical practice. But I do agree with Krishna that actually the only way to improve yourself as a surgeon is actually to learn from every complication that you have yourself, but actually hear from other stories. If you take one bit of snippet from every complication you hear about, you will become a better surgeon. But it is stressful, as mainly as a junior consultant, because of national data collection, or upper GI's NOGCA, and if you're starting off as fresh CCT to a new consultant post and you have a mortality early, it takes quite a few cases to get rid of that, and it's quite stressful. So starting off is really difficult, I think, at the moment with national data. But yeah, but I think I think reflective practice is really important. I think the interesting bar chart you saw before is the ones that say they're not affected. I think they're the ones that you should focus on, as to, when people stop caring about it or don't show any emotion about it, they're the ones who probably, interestingly, might have the same complication over and over again, which is a different issue. But in terms of research you can do from this, looking at personality types, looking at a lot of different arms to it, the other thing that's not appreciated, and I find this quite frustrating, is all surgeons go through a job planning process, and one aspect of your job you can't even quantify is the stress that you get from these sort of situations. And you're comparing apples and oranges with different specialities and different disciplines. But that's something that doesn't get accounted for in our job planning, which is really, and you can't factor it in at all. There's the picture of kick. Every time you see a patient after post-op for 7 days after a leak, you're getting kicked every day. But you can't, you've got nothing to show for it, apart from losing hair. That's it, really. But the other thing that I think is really interesting is it is all about reflective practice, really, and learning from every mistake you make. But sometimes it's not just one serious complication you have. There's a team around you in the theatre room. A scrub nurse doesn't know what she's doing, wrong kit, all these things you can't really blame at the time. It's a lot of these add to your complication, but trying to manage the whole culture and the system is difficult as well when you're trying to change things. So just a few things there.
Yeah. What do you think, Ms. Jimmel, about this?
I think it's a really important topic, and I actually think that the trainees need to be involved with it. While I agree with a lot of the comments that have been made, as a consultant, you take ultimate responsibility and you probably take a bigger hit. I think our trainees also take a hit. They get involved in complications, and I think we need to lead by example. I think communication is key. It's key to have that communication with our patients when there's complication, but actually involving our junior staff, because often they will be involved in ward rounds, in family discussions. And actually, having experienced this recently, I don't know what you found in terms of the study, but it actually wasn't just my own colleagues. It was my colleagues in ITU and how they reacted. And actually, the junior trainees were way better than the senior consultants. The consultant that put in a trachea turned around and said he couldn't possibly have a complication. He did the trachea, which I found absolutely stunning, because I've been very much brought up with, we can all get complications. If you don't get a complication, you're either a liar or you're not doing enough. And for an intensive care consultant to say that absolutely stunned me. And that caused more complications for my patient. And ITU were not supportive at all. But when I pointed out the fact the traumas that I'd gone through, their trainees were fantastic. Their nurses were fantastic. They were really supportive. It wasn't the intensive care consultants. And that stunned me. I've learned loads. My own colleagues, very variable. Those that were aware were supportive. Others were oblivious to it. And I don't know if that resonates with other people, but I've learned an awful lot. And I think I would like that information to go out to my trainees. And I think whether they're registrars, they're SHOs or they're house officers, it's that understanding, because things will go wrong. They're either big or they're small. They still impact all of us. And we do stop and think about them. I think nearly every one of us is reflective, whether we're a surgeon, an intensivist, a physician. That's the nature of how we do things. And it's trying to get that delicate balance between beating ourselves up too much and actually learning from that reflection. The trainees are coming through doing a lot of reflective practice. It's in social media about mental health. And I think it does need to be brought out to the surface, not just by great studies like this. Thanks.
Thank you, Ms. Jimmel. I think, as you said, nowadays, it's I think more than like 10 or 15 years ago, reflective practice now is a common thing with during training periods and getting into a consultant job, so you can be prepared for these negative impacts. Mr. Menon or Mr. Maddock as well, if you want to comment, I think the key element here about facing these complications is like the team structure and having your colleagues around you, and like, as you said, Mr. Menon, discussing this in M&Ms as something to learn from, not only as a blame game. So do you think maybe, especially in complex surgeries, like operating with a double consultant, or asking also help, like one consultant is around, can this mode of operating within a surgical department can diffuse the impact of these complications, or what do you think?
I think all great points, Mo. I think, and thanks to the comments that I've heard from all around, I think it's fantastic to have this discussion. For me, I think, one of the things that Javed, you touched on and Jamshed, you spoke about is this, where is your support structure in terms of it being a large volume center versus a low volume center? I think if you're in a large volume center, you're much more vulnerable as an incoming consultant, where the support structure is absolutely sometimes missing. And you don't have, unless you have a buddy consultant to start off with, you would struggle, because let's say I put you into an environment where you're doing, for example, 200 transplants a year, and you're working in another unit which is 50 transplants a year. You're much more exposed in the bigger unit when you walk in as a consultant. Your innings starts at 0. And as one of my colleagues used to say, only the first 3 and the last 3 matter. People don't remember what happens in between. But I think the support structure is definitely deficient in a large volume center compared to a small volume center. The second point you made about operating together has started to change, thankfully. So I think certainly in transplant units, when you're doing complex cases, we've started to operate as 2 consultants. People have realized that when you operate as 2 consultants, the burden of pressure on you is much lesser. And you actually enjoy the operating much more. There isn't that macho bit. I think it's now referred to the macho bit, where you feel, come on, I've got to do this redo myself. Why should I have to ask somebody to come and help me? And that's going slowly, because you realize it's the patient at the end of the day who needs to come through this safely. So I think there's a lot to be done, but this is a fantastic theme conference. And I think, I'll probably be asking some of you to come and, talk to us in our society meetings. ACP GBI meeting was there last week, and I was there at it. And I think the complications is a big part of our lives. It's not to be underestimated. It's what we walk in with and we walk out with. But I think those 2 points I'll make: center volume and how much support exists within that bigger centers. And secondly, operating as a buddy, there's no question, is a way forward.
Thanks, Krish. Can I just come in there? You spoke about the high volumes units and the not so high volume, or the small volume units. Now, one of the probably the most common operations, which is kind of simple, okay, when it goes on, is laparoscopic cholecystectomy. And if we have a bile duct injury, then it probably will become local, regional, national news. Okay, we all know it's going to happen. It is going to happen. But being at a small hospital where it is done more commonly, do you not think the surgeon is more vulnerable, more worried about, hang on a minute, I'll have to pick up the phone now, speak with the regional, and how is the tertiary center going to respond? You're more worried, aren't you? I don't know.
Completely agree with you. I think the one thing, what I was talking about is the support structure, but you're right. If you then put the same surgeon in a low volume center, I shouldn't say low volume, or less number of cases, the problem is every single complication becomes highlighted into a big thing. And obviously it causes a significant impact on the surgeon who's going through it. And as you say, if it's for a lap chole, then you have to ring the tertiary center. There's a huge degree of embarrassment that goes with it, with that phone call. And I've been at the receiving end of taking these patients on. And my attitude has always been, and as it is with the trainees, and I think somebody spoke about trainees earlier, and we shouldn't underestimate, there are a lot of trainees on this call. And I think trainees are ultimately our colleagues. They're going to be future consultants. I think good old-fashioned cup of tea at the end, sitting down and saying, look, this is what probably you could have done differently, is something that we don't do often enough, I think. Often enough, there is a lot of blame game. You know what, this person went and divided the bile duct, and we walk away knowing fully well that that is a well-recognized complication. It can happen. It's perhaps best to educate that person or talk through them. In Leeds, we had a very good system. I don't know, Catherine, if you remember, we had to video every operation. And 2 instances where there were bile duct injuries, we were able to go back and talk through where exactly it happened with the trainee. So what that does is it actually increases your confidence, because you've actually immersed yourself in the complications, seen at what step you went wrong so it doesn't happen again. But you're right, you get exposed much more in that respect in a low volume center. And the embarrassment that goes, often,
even senior consultants who've done it, your hands are shaking when it's happened. Come on, it's a heart-stopping moment. It's when you divided a bile duct is not something you want to do. As Catherine said, there's a litigious thing that's already in the back of your head. 150,000 pounds payout is going to come out. All of that is attached to it, and that's the burden that you carry. So I think, for me, in all of this, if something comes out, it is, in some way management be convinced there has to be a support structure in place within trust to actually deal with it. As societies, we are doing a little bit. So the BTS now has got one post, which is for mentorship. So we had a few consultants who went through difficult times, complications after complications, actually got annihilated by the trust, and then we had to take them on and support them. So we've got a mentor now within the group who they can contact anonymously, independently, have a chat about things. So it is a way forward again. We have to move forward on this. Sorry to take up more time.
No, that's a fantastic suggestion. I hope more societies go that way. Javed, can I just ask, all of this, what do you think, we talked about the trust or the hospital, there should be support systems. We all do pay, and most of us pay towards the medical defense organization. Do they have any role in this? Should we be approaching them? How helpful are they? Any thoughts, or Jamshed as well? What do you think? What's your experience has been, or what do you suggest to everybody on that regard? Should they be paying this, monthly or national fees towards it? Are they helpful?
I think it would be helpful, but I'm not sure on a national basis it'll probably be doable. I think probably you need to have the structure in your trust where there is someone available for coaching / psychological help, depending on what maybe via occupational health even. That needs to be more available, I think. Another thing that'd be interesting is if that service was available in a survey, how many people would use it? I don't think we know the answer to that. So, but I think it should just be part of wellbeing and the trust at the moment, which is a big hot topic due to COVID and things. And I think it should be part of a recovery plan, especially with pressures that we're getting at the moment, waiting lists, etc., etc. So I think it should be something that's done within the trust, to be honest with you.
Yeah, I think I would agree with Javed on that. I think the Medical Defence Union, if you ask them, I think they do run these workshops on well-being and stuff. So they'll say, yes, we have workshops you can attend. But I think at the end of the day, you need a local support network. So in our trust, we have a consultant who is a well-being lead, and you can make appointments. She's a trained mentor and a coach. And as I said in my talk, I think we have a 24/7 access to a professional counselor now. And that only started with the pandemic. It was non-existent before that. And I think it started because people being affected by seeing sick patient and spending long time in COVID wards. But now it's available to anybody, any doctor, nurse in the hospital. They can ring them 24/7 if they want and seek that help. I totally agree. I think association probably need to do a bit more. In ACP-GBI, we have an early year consultant network now, I think, and we have professional mentors, our senior consultants who are mentoring the junior consultants. So there is a support available now. I think as more awareness comes with the topic, I think there will be more support going forward. But certainly there's a lot more work needs to be done. As I said, every RCA you read, it is never asked in any RCA outcome, how is the surgeon or how is the doctor feeling? It is always, is this happened and we should be doing this and we should not be doing this in future. We do that ourselves, as we all in this call have been through that process countless number of times. When we see anything, any complication happens, we go over that case again and again, going to bed, waking up first thing in the morning on the ward. So we do the self-learning, and RCA just tells us a bit more about it, but it's where that support, how are you, that's still lacking.
Yeah, Suman, did you want to comment on?
Yeah, no, I just wanted to make a quick comment on this,
Yeah.
So when we talk about, coming into M&Ms and discussing mortality, how many of us actually, honestly, the fear that you have, if you had a mortality, to walk into that room, and I can tell you from personal experience, that sometimes almost you have a coterie of your colleagues who will make sure that you don't get shot down in an M&M meeting so that you can get through that 45 minutes and come out alive. And I think that's the completely wrong way to go about it. And that's what we do most of the time. That's why I was referring to M&Ms. M&Ms are a really poor way to actually handle somebody's complication and their well-being, because it just is a tick box, it's done. And often you make sure that you have 2 or 3 colleagues who will be there because you know there'll be dinosaurs in the room, who will come there, who will wait to see what did you do wrong. And I think, it exists in every unit. So I think more needs to be done actually to make the M&Ms worthwhile as well. It's not actually functional at the moment.
There's just a comment on the chat from one of our audience saying that I want to learn more on structured debriefing after patient events. Ms. Smith or Mr. Valia, what do you think? Do you think that debriefing after the complications has a role in managing these impacts, or no?
Yeah, I think it does. I think, as we've been saying, we do it with ourselves all the time. And we probably, if you do have supportive colleagues, you do talk it through and have kind of a debrief. If I ever have a junior who has a complication on a patient under my care, then I will debrief with the junior and talk it through, because they do take a lot of it. And I don't know that they necessarily understand how to process it yet. So yeah, absolutely. I have to say, I'm feeling quite lucky in my trust, as I don't have that kind of experience at our M&Ms. We are pretty much universally supportive of each other and understanding that that in that process. So it's disappointing to hear that people are having such terrible times in their M&Ms, and we need to be kinder to each other. Definitely, everybody gets complaints and complications, so it's going to be you next time.
Agreed. Yeah, any surgeon will have complication at one point of time. Ms. Devalia, do you have any quick comments or?
No, I totally agree. I second that. I think debriefing is a great thing. And I think learning from the Air Force, I mean, I think having simulation scenarios more surgical based, because there's a lot of simulation training, but we don't have as many surgical simulations, which I see. And I think we could incorporate that so that from a very junior level, trainee level, people can get engaged in these simulation. And that could be one of the topics of simulation training on dealing with it. And I think making people more aware and more comfortable in speaking up and expressing themselves, rather than have a kind of a cognitive dissonance, whereas you sort of literally avoiding and probably will cause more harm to your personal health and well-being if you don't talk about this openly. And having the confidence within your department colleagues. And I think there could be a role for an appraiser as well in this, because I think generally when you have an appraisal meeting, though it's only once a year, you do have a little bit of open discussion and you don't feel threatened in that sort of meeting. Its appraisal is a good way to discuss if there were some issues which were hidden deep within and you want to just express, and the appraiser could have ways of helping you. Thank you.
Thank you, Ms. Valia. Ms. Jimmel, do you have any comments or any final comments to say?
I don't think I have anything extra really. I think most of it's already been said, apart from thank you for the talk and bringing this important topic up. I think with the sheer number of people that have joined, it's not just us that find it important.
That's right. Thank you very much, Mr. Sultan. I think you're raising your hand.
It was just one comment to what Krishna said. I agree that the MDT does need to change a bit. And I think one potential idea which I've thought about for our unit was to actually have, because most M&Ms are usually joint with endocrine, breast, colorectal. But what you really want is interspeciality M&Ms. So, for example, 2 specialist centres joining up to discuss some complex cases is more likely to learn from that and get different tips, different way to do things than the generic general surgery M&M. it's just an idea. Not that I've acted on it yet, but it's an idea that we've had at Salford.
Thank you very much, Mr. Sultan and Mr. Maddock.
No, Mohammed, thank you so much. I probably would have just some closing remarks, but before that, I think Oren Saha is a great friend of mine from Huddersfield. He has put a fantastic resource in the chat function for everybody to look at, and that's advice and resources from the Royal College of Surgeons of England. I think it might definitely be worth reading. I'll have a look so everybody can copy that, because I think this is we're going to lose it once we close the meeting. But I would just like to thank everybody. Jamshed, thank you so much. That was a fantastic talk, and a lot of discussion happened. And I think I've made a lot of notes. Catherine, I don't know what resources we have at our trust, but we probably do need to, we can certainly improve and take a few things from here to develop locally. It looks like the local trust, has to offer more support with colleagues and more candidate locally. But thank you, everybody. It was a fantastic talk.
Thanks.
Fantastic. Thank you so much.
I think you probably know, on a lighter note, the surgeon you worked with in Leeds, and Catherine knows him, Steve Pollard used to always say, there's nothing you can break that I can't fix. So I think, it's a nice relaxed way to actually be as a trainee operating major cases. Anyway, thank you. Fantastic talk and a great session.
Thank you very much. Thanks for the invitation.
Thank you. Good night.
Thank you very much. Good night, everyone.
Bye.
Bye.